Okay, folks, we'll make a start. Thank you very much all for being here today. I'm sitting here looking at the attendees, and we're at 106, and that will slowly creep up. So that's absolutely brilliant. Welcome to the RCNi People, Processes and Technologies webinar. My name is Richard Hatchett, and I'm the RCNi Senior Nurse Editor. And RCNi, as many of you know, is the publishing house of the Royal College of Nursing. We're editorially independent, but we're owned by the RCN. And we publish 10 journals, and we also have an events team. And it's the events team that have teamed up with our colleagues at Oran's Medical, and Oran's Medical is sponsoring today's webinar. So a big thank you to them. I do want to say thank you to you all as well, because I know as a registered nurse myself how difficult it is to get away. So we hope today we've got a 2-hour program. Well, I know we've got a 2-hour program that will be both stimulating, challenging, and hopefully will enhance your knowledge in this particular area. So what we're looking at today is people, process and technologies, but particularly in wound care, and looking or emphasising the digitalisation agenda, technologies and innovation. But before I kind of present our first speaker and explain how we're going to run the webinar, let me just go through some housekeeping. Is it tips or rules? Rules sounds a bit hard. I can't tell you where your toilet is, where your fire escape is, where your coffee is, because you know that. But I can tell you that we're going to be recording the event. We're not going to be putting it up on a live platform, but it allows everybody to look afterwards and just see what the thoughts and the ideas are, particularly from yourselves. So just to let you know, we are recording. Also, just to go through the questions, how we're going to do that, you'll see the Q&A box at the top, sort of top rightish of your screen, and I'll invite you, or sort of prompt you to put questions in there as we go through. We'll take questions at the end of each speaker and also during the panel discussion. It's probably easier from experience than trying to get you up on screen and trying to work out amongst, you know, several hundred of you where you all are. But if you can type questions in, you're very welcome to put comments at any time, but there'll be particular points when I ask the questions. And what it also allows me to do is group those together and see what the most popular ones are. And hopefully we won't get through every question, you know that, with lots of people online, but we'll get through the majority of those questions. The other thing is, towards the end of the panel discussion, I'll just get you or invite you to, if you'd like to put some comments in the chat box, the Q&A box, about what your next steps might be when you've heard today's speakers. What might be your next steps, whether that's to get more information about technology, whether to look at finances, business planning, talk to your manager, because it's quite useful for the speakers to know exactly what you're thinking in terms of next steps. It helps us to look at some of the barriers and some of the pushing factors as well. So what we're going to do with our speakers today is we're going to start kind of nationally with Mike Watson in a moment. Then we're going to bring it in a little more locally with Lakshmi, who's a Queen's nurse and nurse consultant in tissue viability. And then we've got a panel discussion with two chaps, Bruce and Peter, who are absolute experts in technology as it's applied to healthcare. So there'll be lots of examples there, lots of discussions about change management and what safety actually means, what are the pushing factors, barriers, and so forth. So I'm just checking I've absolutely covered everything I have, which is unusual for me. I normally leave something out. So what we'll do now is we'll move into looking at this topic from a national perspective. It gives me great pleasure to welcome Mike Watson, who's Digital Data and Information Programme Manager for the National Wound Care Strategy Programme. And Mike is looking at exploring the opportunity to deliver better wound care through digitalisation on a national level. And we'll take a few questions at the end when Mike's finished. Thanks very much, Mike.
Thank you, Richard, and thank you everybody for coming to the webinar today. As Richard said, I'm Mike Watson. I'm from the National Wound Care Strategy Programme. I'm also joined here by Anne Jacqueline, who we work together on the Digital and Data and Information work stream. And so we'll be able to answer any questions when we get towards the end of the session. I'm going to give you a bit of a national view about how we think about this topic. And then you're going to hear from, as Richard said, from Lakshmi, from one of our first tranche implementation sites, and Rebecca, who's leading on the Transforming Wound Care programme. So hopefully these things you hear from me, you'll start to see dotted through some of the work that they're doing as well. So what I wanted to do is, if you next slide, please, is just use my slot. Next slide, please. Again, use my slot to give some context to wound care. I'm sure lots of people here know, but I think it's always important just to sort of ground us in the challenge. Then talk about how we see the role of digital and data in wound care and the improvement and transformation of wound care, and then talk about some of the work that we're doing in those spaces, and then try and highlight some of the opportunities we think that are there. Next slide, please. Next slide, thank you. So just to give some context, I'm sure most of you on this call will know, given the attendees that are here, but you'll probably know firsthand the burden that wound care places on the healthcare system and on your everyday clinical practice. We also know that we're a system under pressure, and that anything we can do to alleviate that pressure is going to be well received. But we know that the wound care places a huge burden on the health and care system. As we've said here, you can see that lower limb ulcers, just picking on those, accounts for 37% of all wounds and takes up 71% of NHS spend on wound care. So huge amounts of effort, huge amounts of money is going into trying to manage these wounds that cause patients poor health outcomes often, and even just poor quality of life. And what we're trying to do is respond to that by trying to establish the case for change, identify what the levers are and the improvements that could be made in patient care, and try and describe the necessary changes and interventions that would fundamentally support the delivery of better wound care across the country. Next slide, please. So I talked earlier about in the last slide about the burden, and I just wanted to indicate the opportunity that sits here. There is a eye-watering amount of money being spent on wound care. There's the opportunity to release some of that back into other areas of the health system is enormous. But you can see here that for those of you that work in community nursing or district nursing, there's a large amount of activity that's spent on delivering wound care to patients. And I think through the work that we've got with that guests produced, you can see that almost 33%, benchmarking produced that 33% of a community nurse or district nurse time is spent on delivering wound care. And there's a role of digital and data within this, but it has to be seen within the sort of the broader lens of the people and process and technology. So the people change, the process change, and then latterly the technology change. Next slide, please. Why is that? So it's due to the variation, the unwarranted variation of care. So on the left-hand side here, you can see this is one of the as-is models of care for one of the sites that we were working with as they joined our programme. You can see it's not necessarily well organised, it's not necessarily well understood across the system, and what that results in is too few patients receiving evidence-based care. And fundamentally running through all of that is that there's a lack of data and information to inform how you might improve that and then sustain that improvement. So what we want to do as a national programme is reduce that unwarranted variation so that we get better healing rates and less recurrence and better patient outcomes, and really try and make sure that we can make the best possible use of those NHS resources that we know are going to be under increasing pressure, certainly within the current fiscal environment. And what you've got here on the right hand side is a view of our best practice pathway. So trying to make sure that we can turn that slightly jumbled picture on the left hand side into a much more clearer model of care that people can adopt. So this is what we're trying to do for lower limb, and we're doing the same work in pressure ulcer and in surgical wounds too. Next slide, please. And then linking back to the topic of the presentation, that we're tackling this through trying to raise the overall capability of the NHS through the people, process and technology lenses. So as a programme, we are delivering or designing and producing free online educational resources to try and make sure that everybody has the right skills and capabilities to deliver high quality wound care. Produce pathways that are redesigned that can take advantage of those capabilities that people have to make sure that we get people into the right services as soon as possible and provide them with the right care at the right time. And then within that, making sure that there's the right technology in the right place to support the clinical delivery of those reorganised or redesigned services. But what I'll come on to in a bit is really just the role of data within that, not necessarily technology per se, but what's the role of technology? Because we know what we want to do is make sure that we're collecting and capturing the right data along that pathway to try and inform how those services are delivered and are improved, and also to see where you can spot variation across the country. Next slide, please. So what does that all result in? So all of that thinking has gone into our national implementation case. So we've developed a business case that describes the opportunity that I mentioned a bit earlier, sets out the big case for change, that if we can change or alleviate that unwarranted variation in wound care, we can make these large savings and produce and have better patient outcomes. And within that, you can see that we talk about changing the model of care, providing educational resources, but flowing all the way through that is the role of data and information. So how can we make sure that nurses and AHPs have point of care digital technology to capture contemporaneous data and information, and make sure that information is being used to inform those services and feeds back into sustaining them. So we think it's only right that nurses and AHPs have that, the right information at the right time, at the right place, and that they can have the ability to document that clinically document what it is the care that they've delivered, and I'll go on to explain why that is. Next slide, please. So fundamentally, when we look at this, we think there's a huge potential in the use of the data that's generated through the delivery of wound care services. So there's huge potential in understanding the patient data that comes in, that is associated with the people that are either or aren't receiving wound care services. So we can understand lots about the patient, who they are, where they come from, what their diagnosis was, what activity is being delivered to them or with them, and what outcomes they might have. There's also the data about the staff that delivering those services and delivering that care. There's volumes of data that could be available to understand what products are being used, what equipment's being used in the delivery of that care. And then also, importantly, there's the experience of patients and staff. So the quadruple aim here of improving the staff and patient experiences of the care that they're receiving. So there's huge potential in the data that could be collected and could be captured. On the right hand side here, what we're taking a view on here is that what we've done historically, though, is we've collected or had this data, and we've tended to use that for business purposes. So we've tended to collect lots of data to make sure that we can support commissioning or contract management or even performance management. So we tend to collect data and then turn that into meeting a business need. And what we would like to say is, as a principle, is that we should be collecting that data at the point of care that I mentioned a bit earlier, but it should be done primarily to support the point, the delivery of care, the continuity of care that a patient is receiving. So the work that you're doing, the data you're collecting should be predominantly focused on improving or on capturing the care that's being delivered, and that can be important because it can help you understand how to improve your care. And then what we want to do is then derive the business needs from that. So we want the data to be collected, captured and used for a clinical purpose first. And then only once we've done that can we start to then think about how you might meet those business needs. So derive the business data and the business questions from the data that you're collecting and using. Next slide, please. So when we've been thinking about this data, what we're thinking about at the moment is trying to make sure that it's all well and good talking about what the data is and what data could be out there, but we want to make sure that we're collecting data that is answering some of the questions you might have in delivering wound care services, at whatever footprint that might be, a service level or a regional level or a national level. So we've been doing is trying to understand what types of questions might you ask, what types of things are you trying to understand about your service, and then make sure that we've got ways of collecting data to be able to do that. So, for example, we want to make sure that we understand the full population of people out there that would have wounds. So not everybody that has a wound is visible to a lower limb service or a wound care or a tissue viability service. There are people out there with wounds that we just don't see and don't understand. So we'd like to make sure that there's data available that can tell you where all those potential people are. Then we want to think about, well, you know, are we clear that if you follow the recommendations, are all those patients getting the care that they need at the right time? And then if they are, is that care delivering reduced healing times? So we're trying to think through what are those big questions that you would need to answer in order that you can then collect data against it and understand whether it's making any change or whether the recommendations are making any change. And quite critically, whether the team's size and shape is changing in response to that as well. So can you identify, you know, who's delivering the care and how is that care being delivered? So this is work that we're thinking through at the moment, and it's informing some of the work that we're doing around the measures and the metrics you might have for services, wound care services. Next slide, please. So with that sort of thinking in mind, we've been very clear, I think, as a program. What we want to do is, if we want to make sure that data is being collected to support clinical use first, that it actually also flows up and down the NHS. So we know the NHS is made up of layers, and quite often we collect data locally and only use it locally. And what we want to do is make sure that data flows up into the other uses of data that might exist across the health service. So, for example, we want to make sure that data flows up into electronic patient records, for example, so that it can be used to support those business needs that we talked about. We then want it to be made available and visible at an integrated care system level to make sure that people can support the continuity of care and also work out whether there's opportunities for commissioning services differently. And then again, we would like that data to flow up into the model health system, for example, so that you can start to see where there's unwarranted variation across services as well. So places can compare how their services are being delivered and understand whether they might make changes locally in response to that. So we've got this notion that we would like data to be collected, really good data, and for it to be supporting clinicians, but making sure that it's also going to flow across the health system so it can meet lots of different needs. So capture it once, ideally, and make sure that it flows through into those other different use cases, but fundamentally supporting the clinical care that nurses and AHPs are delivering. Next slide, please. So as a result of that, we know data. The role of data is critical in the lower limb recommendations, for example, that we've produced. And we want to make sure, again, another demand on the data approach that we're taking is that the data that is being collected flows across the whole pathway. The data needs to be available within, for example, in lower limb, in dedicated services. It then needs to be available and captured and collected and visible in the patient's or person's home, for example, if you're doing outreach services, and then also to be available, collectible and visible in bedded areas as well. So there's a lot. We want to make the data really work across the pathway to support clinicians and to also make sure that it flows up and down the health system as well. So we really want to try and sweat the data that is potentially available, and I'll come on to why I say potentially in a second. So we've got these really great ideas about how we'd like data to be used to improve wound care services, and that thinking is folded into all the work that we're doing in the National Wound Care Strategy Programme. Next slide, please. But with that vision in mind, what does the world look like today actually when we look at wound care data? And quite simply, we think, and through the work that we've done with the FIMPs, and Lakshmi will probably attest to this, that there's an absence of data. So although we'd like this data to work in this way, if you go and look at wound care data right now, it's often just not there. And if it is there, it's not necessarily of good quality that you can make it work in the ways that we've described earlier. And one of the reasons of that is that it's not coded, it's not structured in any way, and it's therefore locked away. It's not visible, it's not available to other people or you to use. And often that's because of the technology that's being used. It's locked away in GP-based systems, so it's often in note form, which means you can't extract it, you can't look at it, you can't do anything with it. There's also challenges with how data is being collected. So, ideally, you would like this data to be collected in a structured way, in a simple way, in a low burden, low touch way. But often there's lots of data being captured on paper, lots of notes, and it can be collected not necessarily at the point of care all the time the care is being delivered. So you have a sort of data quality issue with that. And if you're lucky enough to have a place that is capturing data in a slightly structured way, in a template, for example, in an EPR, there's variation in those templates. So the same bits of data will be coded in different ways. So it means that we can't then start to compare it. And then what we also see as well is that there's often a variation in how that data is reported and used. And I'll come on to the CSDS in a second. But ideally, we want to be collecting all this data so that you can, as professionals, use it to deliver your services and improve your services. But if it's locked away and it's not structured, it just means it's not visible to us today. And one of the phrases we use here is often that wound care services are operating blind. Unfortunately, we're just not clear on the huge burden that wounds have across the country, and how well services are performing or are delivering services again to those patients that have wounds. And we think some of that's down to just how data is being thought about, and also how data is being coded and collected. Next slide, please. So if that's the situation, what is it as a national programme we're doing about it? It's all well and good having this vision and being able to describe what we see today through our work. What we're trying to do here is make those changes nationally that we think can improve the delivery of wound care, and we have a very big data theme on this. One of the things we've done is this year we've commissioned the Professional Record Standards body to help develop a national wound information standard for the 3 wounds that we talked about earlier, for lower limb wounds, for pressure ulcers, and for surgical wounds. So what we'd like to try and arrive at is to define essentially a national standard for wound information. So if we can define a national standard, we can then standardise what that data, how that data is collected, and we can then standardise how that data is stored and made available to others. So what that can do is help us signal to EPR supplies around about how we'd like data to look and how we'd like data to be stored. And if we can do that, we can also then hopefully try and see if we can lower the barrier to making data available across a pathway, so removing some of those interoperability problems that we often hear about nationally. So what we want to try and do through the standards work is do exactly that, is standardise wound information to make it comparable and available to you locally in the work that you're doing, and to make sure that it flows across the pathway that I described earlier, but also is available at those different levels in the NHS as well. And that work's just started. We've just had the first round of consultation exercises on this, and the PRSP are now taking that consultation input away and are impacting it for another round of consultation in early November, I think it is. And I'd encourage any of you on the call that are interested to take part in those consultation exercises. That work really will help us try and define what we think a national standard needs to be, and then that will hopefully mean that if people have bought into it and have contributed to it, then the take of that standard will be better, and we'll have more leverage to make it standardised across the country. Next slide, please. What we've also been thinking about as well is making sure that the wound care data that is being captured and collected, and if there are routes to doing that, can be made visible and made available to people. And one of the things we've been looking at is whether we can make changes to how people are using the national returns that take place already. So, for example, the community services data set. So we know, for example, that data does get collected, even though it's patchy and necessarily not complete across the country. There is some data being collected, and that data is flowing into EPRs and flowing out into CSDS. What we are looking at here is quite often, though, what happens is that data that does get collected gets tagged under a service line or reason for referral. And we think that what that means is that the activity that the nurse or an AHP delivers against that for that patient just gets hidden, because the reason for referral doesn't relate to the actual clinical activity that takes place after that referral. So somebody might get referred for one condition but actually be treated for 3 or 4 others. So it's not representative necessarily of what nurses are doing with that patient, and so it's not representative of their actual work that they're doing or the activity that's going on. So we just think it's hidden, and if we can't, if it's hidden in that way, then we can't make any recommendations or make improvements around how services can be delivered. Next slide, please. What we've been thinking about is, well, actually, can we make some what we would think would be relatively small changes from a data perspective that might improve how we can then use data. And one of those is whether we might shift from this idea of using reason for referral and start to shift that thinking to diagnosis. So if we can capture a wound diagnosis in the EPRs that are being used or in the digital systems that are being used, then that would mean that we can track patients, because you can see that they've got lower limb wounds and that patient is being tagged through those data sets, and that you can then start to manage the cohorts of patients much more effectively, because you can see them. You can see that there are a group of patients with lower limb wounds, and at the moment the systems that we do have just don't enable us to do that. And we're doing some work nationally to try and see if we can shift some of the thinking here around making sure that the data that you are collecting is being made visible and given back to you so you can use it. Next slide, please.
A couple more minutes, Mike.
Thank you. This is I'll quickly rattle through this, but essentially what we want to make sure is that we've got, as a program, we've got these principles around data collection. As I was saying earlier, that they're clinical first and business second, and that given that we know the data isn't necessarily that good, it makes sense to get started. So use the data to improve the data. So where there are holes, let's go and, using the data will show us where those holes are, and we can improve on those holes. One more slide, please. There's a couple of things now about opportunities. Next slide, please. What we've done is so that's a data point of view. What we've done is try to think about, well, what functionality, what digital things might help us both collect that data, but also provide clinical utility back to nurses and AHPs. So we've taken a huge exercise, an engagement exercise, to try and describe what we think good looks like in terms of digital technology and digital solutions for wound care. And there are opportunities within each of these boxes where we think that this is what a digital system would need to do in order to support the collection of data, but also to provide value to frontline clinicians. What things would you want a digital system to be able to do in order to support your wound care work? And we've made this functional overview available on our website, and we would encourage people that are buying wound management digital systems or systems to support their changes to take a look at that and see if that can help them make sure that they're thinking about their requirements. I've talked a lot about data, but there are functional requirements that you might need to think about as well. Next slide, please. So I think finally, just to summarize, I think when we think about the opportunity, we would say that I think the opportunity here is not necessarily in the functionality. Functionality is great. We need tools, we need apps, we need things that can help improve and ameliorate and support pathways. But there's real value in high quality data, and that data helps you both sustain the services that you're changing and improving. But as we look forward, we could then start to use that data to provide insights you might not have today. So we could use that data that you're collecting to then look forward and think about whether we can identify patients that don't necessarily appear in wound services, whether we could identify through the data that we have whether there are risk factors and flag up people that might be at risk of those factors. So we could start to become much more predictive and proactive in the use of the data, rather than just collecting it and making sure that it's working for business purposes. If we get the right data in the right place and the right structure, the opportunity there is to really try and give that data back to nurses and to AHPs so that they can really look after their patients in the best possible way by asking questions of the data that's being collected. The potential of the data is huge. We now need to start thinking about how we collect it consistently, store it consistently, but more importantly, give it back to nurses and AHPs so they can start to make changes to their practice. Thank you.
Great, thanks, Mike. Just a quick question from me, because obviously this is incredibly challenging, isn't it? And we were talking off camera about the whole concept of change management, and it's connecting you to very much what's happening at the grassroots level. I presume there are champions, conduit people, really, nurse consultants and academics, and I presume people like Luxmi that will glue these pieces together between you and, you know, up there and what's happening at the grassroots level.
Absolutely, yeah, and I think Luxmi is a really good example of that. So, you know, we've got these, you know, these concepts and these ideas, and we're very clear about the principles that we want to try and apply. And then what Luxmi is doing is actually the hard work of trying to work out, well, how do you actually make that happen? So, it's, you know, easy said, harder done, isn't it? And I think what it is Luxmi is doing a lot of good work to try and understand, well, what actually data can I collect? So starting from some fairly basic principles. And then if we start to improve the collection of that data, then can we start to take advantage of it? But you're absolutely right. Luxmi is one of those advocates that we're working with, which is what the role of the first tranche implementation sites are.
Okay, so nurses doing all the hard work, Mike. Never.
Yeah, and somebody like me waving their hands around saying it should look like this. Absolutely.
Yeah, absolutely. Thanks ever so much, Mike. That was absolutely brilliant. And I'm aware of moving over to Rebecca Whiting now, because Rebecca's got the impossible task of doing everything in 10 minutes by the look of it. So thanks, Rebecca, for looking at the role of academic health science networks, national improvement programs, and Rebecca is the Transforming Wound Care Programme Manager for AHSN. Thanks, Rebecca.
Thanks, Richard, for that introduction. Good afternoon, everybody. So I am Rebecca Whiting. I'm the Improvement Director in the Southwest AHSN, and I'm currently leading the AHSN National Programme of Transforming Wound Care. So I'm here to talk to you about the role of the AHSN national programmes and how to make contact with us if you'd like to engage with us on your journey of implementing recommendations of the NWCSP. Next slide, please. Lovely, and next slide, please. Thank you. So I'll start by explaining who the AHSN network is. The Academic Health Science Network was set up by NHS England back in 2013 to operate as the key innovation arm of the NHS. AHSNs were established to transform how the NHS identifies, adopts and spreads innovation. 15 academic health science networks collectively make up the AHSN network, and we operate simultaneously as a single national network and individually as 15 locally embedded and integrated organisations. We're funded by commissioners from NHS England and Improvement, from the Office for Life Science and from partner contributions, and each AHSN team is typically around 40 to 45 people. Our commissioners agree a set of national priorities for AHSNs to work on, harness the collective expertise on key challenges and include the adoption and spread of innovation. Next slide, please. Thank you. The ambition of the AHSN network is to improve lives through health innovation. In my experience, there's a spectrum of where the AHSNs operate. At one end, we have people working directly with the innovators, supporting them to bridge the gap between their innovations and the reality on the ground in the NHS. And we support real-world validation of new innovations. To give you an example of this, an innovator might create a new app or a digital system for monitoring wounds. Their local AHSN might support them to link up with clinicians who could try using the digital system on the ground and feedback about what works well and what needs changing. We also support the innovators to think about where their innovations consider the NHS net zero policy, and also support them to consider their innovation from a health equity viewpoint, encouraging them to use patient and public involvement to ensure a really diverse viewpoint on their innovation. At the other end of the spectrum, we support the spread of innovative practice. And this might be less about a tangible innovation like an app or a digital system, and is more about supporting clinicians to do things differently. There are some good examples of this, such as the current national programme focused on polypharmacy. Our national programmes are identified in collaboration with our commissioners and partners, and often by scaling innovations that the AHSNs have supported and tested in a real-world setting, which offer benefits nationally. This means that every one of the 15 AHSNs has the same priority, and we work locally with our systems to support the adoption and spread of the innovation. During COVID, this included supporting implementation of the National COVID Oximetry at Home model and setting up COVID virtual ward pathways. This year, the priorities include early intervention eating disorders, improving diagnosis of ADHD, polypharmacy, and also transforming wound care, amongst others. Next slide, please. Thank you. So as an improvement director, I love this Lego slide. That's because I came across it many years ago when I was working clinically and as an ops manager in a really very rural setting with pockets of high deprivation. I felt like I was constantly firefighting and prioritising, and seeing this slide, it reminded me of the need to keep going with the service improvement and redesign work I was doing to ensure that in the future it was easier. I actually met the HSN a while later, who came and supported with some transformation work and were providing examples of where it was being done really well elsewhere. And they linked me up with other areas of the country with similar demographics. I'm sure you'll agree that the NHS is full of square wheels, and Mike has talked through the statistics, which indicate the sheer scale of the issue the NHS has with managing low and in wounds. The HSN network is there to not only support the NHS to find new shaped wheels, but to support them with the process of moving from square wheels to round ones, and there's plenty of challenges in that in its own right. So what does this look like for the new National Programme of Transforming Wound Care? And how does the HSN network support you to make the improvements? So firstly, we recognise that the need to raise awareness of the NWCSP recommendations. Everyone here will know that tackling the issues managing patients with lower limb wounds are system-wide issues. They're not just housed within primary care or housed within community services. HSNs will support ICBs to recognise the need for collaboration across the full health and care system, with the aim of finding early adopter sites to build on the work of the first tranche implementation sites, which is the work that's been led by the NWCSP. Our role will then be to act as the conduit between the sites to share the learning. We'll encourage sites to develop inclusive approaches that take into account health inequalities in decisions of both design and delivery, and this can be done by supporting the use of equality impact assessments and harnessing patient and public voice partners. This helps sites to focus on the patient experience and outcomes, as well as considering the approach from a staff or cost perspective, and this truly encourages a person-centred approach. Next slide, please. Thank you. So far, 6 HSNs, so you can see here on the left, this includes East Midlands, Eastern HSN, the Health Innovation Network, which is the HSN for South London, Kent, Surrey and Sussex, Oxford and the South West HSNs have been working together as part of the Transforming Wound Care programme. They've been engaging the systems, seeking the next phase of sites, who will be called test and evaluation sites. I'm pleased to say that we are onboarding new sites this week. Over the coming months, the remaining HSNs will be bringing on the next phase of sites to work to implement the NWCSP recommendations with the support of their local HSN. Next slide, please. The HSNs will work with their sites on the 3 programme elements that Mike's already talked through. So people, increasing awareness of the education available and supporting with workforce mapping and gap analysis. Process and service redesign, considering the differences in urban and rural models, and finally the implementation of technology and the behavioural change that's required to achieve good implementation, as well as supporting the conversations and challenges with data capture. The HSNs will be supporting with the practical implementation of the 3 elements on the ground and using quality improvement methodologies to support the real-world implementation. The anticipated outcomes will be faster wound healing, improve quality of life for patients, reduce likelihood of recurrence, and using the health and care resources in the most effective and efficient way. Next slide, please. So if you feel like your service has square wheels, or you'd like to find out more about the Transforming Wound Care programme or the support the HSN network can provide, please get in touch. There's an email address on your screen. Thank you.
Thanks very much, Rebecca. You're the perfect speaker. Timing to a T. Thank you for that. Just as you'll probably notice, both, but this is one for Mike or Rebecca while we've got 2 seconds, is Diane is asking about any other countries capturing this kind of information, for example, Australia and New Zealand. You know, are we learning from other countries, or are they linked to your slide, are we reinventing the wheel? You know, are others doing this overseas that we can learn from? I don't know whether Rebecca or Mike, you wanted to pick up on that one.
Hi, yeah, I can come in. We have learned certainly from other countries, and I think our minimum data set is informed by the work that they're doing. I think so. I think the short answer is yes, and we're certainly not trying to reinvent the wheel. And I think part of our data strategy that we talked about earlier is trying to make sure that we're leaning on the work that's already taking place here as well. So there is already methods and ways of getting hold of data. I think what we want to do is try and make sure that we're really exploiting it and taking advantage of what's currently there. That we will have some unique challenges, I think, because of the health system that we've got.
Yeah.
We are organised in a particular way, so sometimes how that data can actually flow is going to be quite specific to us, and there'll be problems that we have. So I think the notion of data flowing we can take from other countries, but actually when it comes to the practical implementation of that, it is quite nuanced to England.
Yeah, absolutely. Great. Thanks, guys. That's super. I'll push on a little bit if I may, because trying to get as many people as we can. But folks, do put your questions in, and when we get those key points, I'll drop them in to the speakers. Okay, we're going to look at a community nurse's eye view using digital effectively to offer evidence-based wound care. And Laxmi is here, Laxmi Dahumoon, who's Queen's Nurse and Nurse Consultant, Tissue Viability, Central and North West London NHS Foundation Trust. Hi Laxmi, over to you.
Hello everyone, thank you to the RCNi and National Wound Care team for giving me this opportunity to share with you how using digital solution can effectively offer evidence-based wound care in the community. My name is Laxmi Dahumoon and I'm the Tissue Viability Nurse Consultant for Central and North West London. The objectives of this session is to show you how, from a community nurse's eye, we can view the future of wound care. We can also use digital to improve partnership with our service users. And how can digital be user-friendly for everyone? Now let's look at what's the facts. Wounds are a serious public health, and despite the large prevalence and crucial information such as prevalence rate, wound types, treatment type, approaches are not always properly documented. But let's look at what happened pre-COVID-19 in the community. Pre-COVID-19, we always carried face-to-face assessment with patients. We will share care with other healthcare professionals to manage the wound of the patient. We will only self-care with those who were unable to keep regular appointments due to their quality of life or working time. Hence, the delivery of care with patient was mostly focused between healthcare professionals. And we use spreadsheet to capture data, like for example, the healing rates, the recurrence rate, the referral to treatment time. And all of these are time consuming with more administrative process and less nursing time. We relied on GPs and practice nurses to send photos to services so that we can review and screen the patient referral for urgency. But what did we learn from COVID-19? We learned to use technology in a different way. We use mobile phones and email to get photos from patients and other healthcare professionals, for example, nursing home. We introduced different care pathways electronically for better communication with the patient and with other clinicians. We encourage relatives to share photos to clinicians, as sometimes the patients or service users did not want to visit for fear of contracting the infection. We started the self or shared care approach with both patients, carers, and relatives. And we began at the approach of a new self-care model where we actually encourage patients and relatives, both informal and formal carers, to support the patient and deliver the care as per the wound care plan. And this was reviewed regularly to make sure the care plan was still effective and efficient for this patient wound type. In places where there were outbreaks, healthcare professionals, for example nursing homes, would share up-to-date photos with the clinicians to make sure we are providing an up-to-date wound care plan. What do we need and from what we have learned from COVID. We have learned that caring for patients with complex wound can be complex, and the chances of poor outcomes are very high if wound care is not optimized through evidence-based protocol. Hence, we need to harness the power of big data analytics to help nurses and physicians and patients provide optimized care based on the evidence. We need to use technologies to revolutionize advanced wound care. What goods look like to me from a community nurse eye point of view, that we need to improve data and information to support our clinical decision making and also to enable quality improvement. We need an updated app with wound care information for all clinicians at all levels to use. We need to reduce administrative load, and how do we do that? By reducing the number of spreadsheets for the various key performance indicators we have to report on, and the digital app should be able to provide that information with less administrative input. This will enable us to release more nursing time and having more time to care for our patient and engage with our patient. We need to agree treatment objective with the patient irrespective of settings, and we need to be accessible to patient to monitor and update their wound care plan. So the data recording and outcome populated from the information inputted needs to be accessible for the patient to monitor their wound in their own settings, in their own comfort, and also for the healthcare professionals to monitor, knowing that the wound care is working. What good looks like from a community eyes point of view is what you can see in front of you. The need for quality improvement, the need for good data recording, the need for to be patient focused where we agree specific treatment with the patient irrespective of their care settings. And we also need to look at removing or reducing administrative workload so we can release better nursing time to care for our service users. I hope this has answered some of the questions we raised from the objectives. Thank you very much for listening. If you do have any question, I'll be more than happy to support.
I mean, Mike, did you want to pick up on what some of the key points that you found in working with Laxmi?
One of the big areas I think that Laxmi has found is what Laxmi has been doing for a long time is collecting data around her wound care service. You know, in the background, she's been using some fairly belt and braces technology, you know, Excel spreadsheets, to try and track her patients and try and track the care that's being delivered. But as I was saying in my slide, you know, that's really good in terms of helping her be able to manage her service, but it sort of means that again the data is not available for other people to look at, and it's not available for people to take advantage of. So one of the things that Laxmi's been doing is trying to make sure that she can you know, collect that data consistently and try and make sure that she's got her nurses and her HPs and podiatrists to sort of you know, engage with the process that she's put in place. So I think one of the big learnings straight away is you know, that need to try and to get a grip on about what's happening today and what work is taking place and what data does she have available. So she had a fairly good sort of longitudinal view about what was going on, but was trying to make sure that she could make that try and respond to some of those questions I posed earlier. So could she identify healing rates, for example, across all of those patients? You know, could she evidence the impact that she was having with that through her service, which is amazing, by the way, to those that are really interested in it. I
mean, she's one example, and I presume, you know, we've got so many different people with different abilities, experiences, and you were saying about the difficulties in applying overseas models into the UK. I presume that's the same with individual people as well, that I presume Laxmi, like today, is sharing, you know, her journey, but also other people, it's not going to be so easy. They won't have other things. Did you pick up what were some of the things that really pushed it for her, the things that she got in her environment that worked, and other things that people could learn from, I suppose?
I think I wouldn't. I mean, I think we're still working and learning that through Luxme. Luxme's work only started with us a few months ago. I think what I can do though is talk a bit about some other work that we've been doing. So one of the things we've been quite conscious of is that, and I'm sure Pete might come on to this a bit later, is that the adoption of digital technology isn't easy and straightforward. It always feels like it's quite a simple thing, isn't it? And we talk about it being a change management process. We talk about it being something that needs to be done carefully. We commissioned the behaviour change team within NHS England to try and help us understand what those barriers might be to adopting digital technology. One of the key messages that came back is you've got to make it really, it's got to have some utility. It's got to be very useful for the person that you're trying to ask to use it in how they're delivering their care or their activity. So if you're a community nurse and you're going into a patient's home, there's got to be a reason why you need to use a bit of digital technology. It's got to add some value back to you. And we often, and my presentation admittedly talked a lot about data collection, but actually what we need to do is almost like describe how you can make technology work for that person, that nurse or that AHP or that podiatrist at the time that they're trying to deliver their care, and give them some value, give them some use from the technology that they're using. So it does support them in the work that they're doing. And it was even something as simple as being able to plan the car trip. So can I use a bit of technology that can help me understand how to schedule my day, how to best organise it based on what I know, because people know what works and what doesn't work, and what they wanted to do was get some aids to try and help them organise their day. So one of the things that we've been learning, I think, is more about making sure that digital has responds to a user need that a nurse or an AHP or a podiatrist might have. And it's only once you start to do that do you get that adoption. And once you've got that adoption, you can then start getting more, the data that we're really interested in, and you can start to take advantage of that data.
Because the slide that Rebecca put up, is amusing, but it's probably there's a lot of truth in it, that people are, trying to move a cart without a round wheel. And I think your point's quite important about, I know when I grabbed my new phone, etc., for a few days I couldn't make a phone call. I just worry about almost that overlap, well, actually more than a few days, that overlap of, and we'll touch on that later about patient safety. Is there a period of time when actually care may drop in quality because they're trying to bring in technology that people don't really understand? One presumes there has to be an overlap and a withdrawing of the old way of doing it and a movement into the new way, so that you're not saying, actually for about 3 months we were trying to learn how to use this technology.
Yeah, and I'll just share a personal view on that. I think I think this is where we need to learn a bit as well from just, we talk about digital, but sometimes I think it's about being digital as much as using digital technology. And I think it is about doing things in an iterative, bite-sized way. So what you're not trying to do is get somebody to, big bang implementations are, we know there are problems with those, and that does introduce risk, and it does introduce, big drop off in productivity. If we can iteratively release bits of functionality that help somebody, then the adoption curve is easier and smoother.
What we'll do, folks, is we'll take a break. My suggestion is that we come back at 1 o'clock, because that gives us an extra 5 minutes on the panel discussion. So we can kind of use this to our advantage when I'll bring in Dr. Bruce Davey and Peter Hansel, who's co-founder and CEO of Isla Care, who have particular expertise in technology remotely. So we'll if that's okay with everybody, we'll come back at 1 o'clock. But please do use the time, as well as making a cup of coffee, to put your questions in the box on the subjects and aspects that we're covering, and I can take those to the panel as well. So I'll see you back here in about 7 minutes, if that's all right with everybody. Right, folks, hopefully you can see and hear me. We're going to move into the panel discussion now. It gives me great pleasure to introduce Dr. Bruce Davey, who I believe is in New Zealand, and it must be about 1 o'clock in the morning over there. So, I think, Bruce.
That's exactly right, 1:03 a.m.
There you go. There you go. So please keep awake for us. And also Pete Hansel, and Pete's here as the co-founder of Isla Care, and he'll tell you a little bit about that as well. But both guys are real experts in the application of technology in healthcare. So do put your questions in the box, folks, but as you can probably gather, I rabbit on a bit, so I've always got a question or two. But can I ask you guys, we've got a lot of things to cover, but can I ask you what, in your view, the technology is looking to do and what we've learned on that journey so far? Do you want to start with that one, Bruce?
Sure. Thanks. Thanks, Richard. Yeah, so around medical, we've been developing technology for managing the collection of data on wounds for more than 18 years now. So we've had quite a lot of experience in this, and we've been through several generations of technology as the technology has evolved as well. I guess what we feel and what we've learned from talking with nurses and clinicians over many years is people want technology that's simple to use, that is quick to use, doesn't interfere with what they're wanting to do. It captures images, it captures measurements. Those measurements have to be trustworthy, they have to be accurate. It needs to capture clinical notes, preferably in a structured way so they can be viewed later. And it has to show very quickly the healing progression of wounds. And then it was touched on earlier in this, it needs to interoperate with other medical record systems that the organization may have. So foremost, we'll probably get to this later as well, but the technology has to fit in with what the clinical pathways are and what nurses are wanting to do. It doesn't have to be something that's burdensome for them to use. It has to be very simple and easy and quick, and provide value. So I guess that's our kind of thought. If it doesn't meet there, it's not going to be as widely adopted, and the most important thing is that information is being gathered, and that the systems are easy enough and encourage people to use them. Yeah, so that's a point from me.
I mean, Peter, I'm guessing you, of course, agree with that. And I'm guessing, is there anything you want to add to that? I mean, how do you see this, what technology can offer, and what we have learned so far on the journey?
Yeah, thanks, Richard, and thanks, Bruce. Yeah, I certainly agree with everything that's been said. I think the thing that we find very exciting at the moment is that the way that technology is developing is really opening up a huge opportunity for lots of different people, lots of stakeholders who traditionally have been kind of viewers of the healthcare system and the way that healthcare processes operate. It's starting to allow those stakeholders to be much more proactive and to really kind of drive the way that care is delivered. And so I think we're very excited by the potential for patients and for carers and for family members, and really everyone else who's kind of part of that support network around patient, to begin to contribute data much more actively. And so that's something that we're doing at Isla Care, certainly across wound care in a very big way, but also across a range of other specialties. So yeah, I think that's going to be a very important shift, which has started and which we'll continue to see over the next decade.
I mean, thinking about from your own experiences and thinking about success stories as well, those organisations that you've worked with, almost bringing it into like a force field analysis, you know, there's all pushing and restraining factors. What do you think are the, have you seen that really push getting technology in there? I mean, we've touched on this morning about, you know, the possibility that it can be a bit frightening, that you've got to have that period where you've got to change management, etc. But I wondered what you've seen some of the pushing factors are and what you see as some of the restraining factors, so that people can kind of work on those. I mean, hand over to you, Bruce, on that one.
Good, thanks, Richard. So pushing factors and pulling factors. So I guess we've already spoken, or that was already spoken earlier in this session, about how strained healthcare providers are, how little time they have, and how there's dramatic increases in the number of wounds that are being treated. So we've got kind of compounding factors here with more wounds and an overstretched workforce. So the pulling factor, I think, is making wound care more efficient, being able to gather the information quickly, accurately, make accurate diagnoses of the patients, and get that information to the people who are making decisions. One of our users once they implemented our system, they decreased the time by 70%. So it went from an average time of healing for a wound of something like 33 days down to 10 days, and from the implementation of our product. So it's using that, having that information available, using that information, and making that information work in terms of creating the improvements and efficiencies of the healthcare system. So that's definitely the driver of this. We saw Mike earlier talking about what data can do. Once you're gathering that data, you're getting the evidence, you can make evidence-based decisions and share that data very widely, and people in the multidisciplinary team who might be caring for the patient. So it's really making that data available in a way that can drive efficiencies in the care of the system. Yeah, so that would be pullers. There are constraints. People are, as human beings, we tend to be resistant to change somewhat. And so introducing new systems does require people to accept change, and have that change has to be managed. So there's a whole bunch of things around ensuring that there's buy-in from all of the stakeholders that are involved as well to get this the solution embedded.
I mean, it's quite an interesting one, isn't it? Because people can be pushing out restraining factors. Yes. Interesting you said there, before I hand over to Pete, that all of the stakeholders. I mean, you don't need everybody involved, do you? As long as you've got the movers and shakers who will take the leadership forward. I presume, you rather like Luxme, you've got those who can show that it can be done and move it forward. You will never get everybody on board, I presume, but you can get some key people, some key movers and shakers who move it forward.
So you absolutely have to have the strong clinical leads, people who have the vision to move it forward. But those people do need support from many other parts of the organization. There's IT systems involved, so you have to have the IT people involved. You need the nursing staff, the people who are going to be using the systems. As Pete mentioned before, you need the patients to be engaged, and if you're gathering data in the home, the patients have to be engaged. So you need a change management program that's just not focused on the clinical lead who's driving the initiative. It needs to be kind of across the whole organization. It has to be kind of behind that implementation. Otherwise, things just run out of steam. That's what that we've discovered is in some situations as well. So you need to have a team of people, a team of stakeholders who are behind the product, or behind the implementation of the solution. So, yeah.
I mean, Pete, picking up on that, pushing and restraining factors, can you also comment, Pete, because it's an interesting point that Bruce has raised about the patient involvement, because you've worked a lot with remote systems, I believe, and I'm wondering whether I'm just thinking of my very elderly parents. That's what's buzzing through my head in technology, and an elderly mother who can't even text. I'm wondering, this patient issue here is quite an interesting one. So kind of pushing and restraining factors, but with a patient perspective as well.
Yeah, thank you. I'll try to do that, certainly. So I think the first thing that jumped to mind when you mentioned the kind of the factors involved. I think one of the things that's really positive is that we're starting to see, to Bruce's point, we're starting to see the emergence of roles that are really focused on implementation and on making a change. So we're starting to see kind of chief digital nurses arrive in organizations, and those are people with, like, admittedly probably not quite as much time as they would like to have focused on implementation, but at least a proportion of their role is carved out specifically for making digital change happen. And that 5 or 10 years ago, that wasn't the case. We were asking for significant digital transformations to be done, really just as an adjunct to people's day-to-day role. And I think there's a growing recognition that that's just not practical. Like, it's a big change, and it needs a team of people, both from the provider and from the supplier, to make that happen. So that's to come to the kind of the patient point. I think we are, the question of technology uptake, and particularly across different demographics, is a very interesting one. We see much less in our data, and the responses from patients to text messages from Isla with secure links so that they can submit their information. We see much less variation than I think the rhetoric suggests. So even in the kind of 70 to 80, 80 to 90 age brackets, we see very good submission rates. The really key thing there is to make the process as simple as possible. I'm sure the RCNi team will agree. You probably can't expect people who haven't grown up around today's technology to be downloading iOS applications and installing them on their devices and kind of setting themselves up and technologically enabling themselves. But what you probably can expect is somebody to follow a very clear set of instructions. And if you can build a solution which guides people through a workflow where really what they're doing is reading and digesting information and then kind of clicking to take the next step, then you see very high uptake. And so I think that's a crucial responsibility really of suppliers who are trying to help to bridge this gap between clinically submitted information or clinically captured information and patient submitted information.
Yeah, it's sorry, Bruce, did you want to pick up on that?
Yeah, I might just make a comment there. Often it's not the patient who would be taking the image in the home as well. It's some caregiver of the patient. And so you might have an elderly, your elderly mother, Richard, who doesn't know how to text, but there may be somebody in the home who is more able to actually capture the photo and enter the information. And so often we find it's the caregiver who's there is the one doing the imaging and the entry. So.
Yeah, this is actually, and it's like the conduit that word was mentioned today. It is an important point, isn't it? I take your point, Bruce. I'm sitting here talking about my mother. I never thought I'd be doing that. That she had to take a picture of a wound. You're absolutely right. I could not do it. There was nobody there to do it. I don't do that. And I think also COVID has brought that, sudden need to technologically connect. Not going to happen, so it's quite interesting. I'm trying to kind of put the problems in and where the solutions may be, but you're absolutely right, Bruce. There isn't that person there. I can't take a picture on my phone. I want to go and sit in the surgery. I want to sit here. I can't do that. So it's interesting to have that. As you said, it's not necessarily the patient who's going to be doing it.
There are definitely barriers, like my mother doesn't even have a cell phone, and she definitely wouldn't be able to capture an image with it. So it's not going to work for everyone, but she is in a place where people could capture the images though. So
absolutely.
And so our solutions, we've tried to keep away from having apps that are installed as well. So it's just very simple to use the phone and just a standard phone with the way we're moving. So anyone in the home with any sort of mobile device can capture the information very, very easily. So.
Can we move on to the word integration, because that was mentioned when we were talking before we went on. And the importance of integration of systems, etc. I mean, Pete, did you want to pick up on that one? Integration is everything, isn't it?
Yeah, certainly very, very important. I think integration and the challenge of integration is often one of the kind of primary hurdles or blockers to adoption of new technology. And in many ways, that's absolutely right, because you don't want to implement 1,000 innovations and have 1,000 data silos. that's a crucial thing to avoid. But in order then to facilitate and drive kind of technology forward, we need to make sure that we're incumbent platforms and suppliers are kind of moving forward at the same rate, and so integration timelines move from 18 months to something a little bit more reasonable. I think I can really understand. Well, there's so many reasons why integration is so important, but like for one thing, people are very busy, nurses are very busy. You can't realistically expect people to be jumping between hundreds of different applications and systems in order to get the information that they need. So it's a really crucial thing, and we've spent a lot of time integrating with kind of the primary EPRs in that are used across the UK, but it has taken us ages to do that, and that's been a real blocker to adoption until quite recently. We only finished our latest integration with System 1 about 4 or 5 weeks ago. So yeah, it's a really crucial thing, but I think what the industry needs to do is try to help to reduce those timelines as much as possible so that we can bring new technology to market sooner.
I mean, Bruce, picking up on that integration issue.
Yeah, so we've had quite a lot of experience integrating in various places around the world, and I'd also comment that an important part of integration is the workflow. So it's one thing to get data moving between systems, but you also need to ensure that the way the clinicians, the nurses and the doctors are interacting with the system, or anyone who's interacting with the system, it fits in with what they're wanting to do, and it kind of is a natural workflow. So we spend quite a lot of time working on what those workflows are to ensure that there's not extra work being placed on the clinical staff. So there are international standards for integration, but it's not, as Pete said, it's not trivial to get that done, and it does need to be thought about and planned and care taken there. So.
Okay, can I just some of the notes they gave me were how can emerging technologies deliver safer and more appropriate wound care. I wonder if we can unpack what that safer means from your experiences of the work that you've done. How can it be safer, and is there a risk that, as we were saying earlier, it could be, we were talking with Mike, it could be unsafe to start with if you're bringing in, I think you've addressed probably that with the bite size and conduits and people and things, that because what you want, I presume, is to move from safe to safer with technology. So I'm wondering what that phrase, how can this technology make things safer, what actually we mean by that, and how can we ensure that that's a smooth pathway? Bruce, did you want to, pick up on that?
Sure. So I guess we're wanting to ensure that the patient is getting the right care at the right time. So with this technology, it allows information to be gathered and shared pretty much instantaneously, so that the information is available to people who need it. There's also the question of risk and when do consultants need to be brought in to address the care of that patient. So with this, once you've got the information digitally, people can access it. There can be alerts that something is not quite right, and people can immediately get access to that information. So I guess there's also the whole question of the sorry, my computer just beeped at me. There's the question of well, what was I thinking about? Sorry, I've lost my train of thought here. But the question of the patient getting, it's too early in the morning for me. The patient getting the right care at the right time, and so you can provide that care to people who are remote as well. So you might have somebody who's living in a remote area, and through telehealth, which is what these systems essentially are, then you can get that information and provide more equitable care to patients in more rural areas as well. So I guess that's a thought, but I'm sure Pete has some thoughts about that as well. So.
Okay, Pete.
Thanks, Bruce. Yeah, and yeah, I mean, you know, I completely agree with all of that. I guess I think something that's quite important to recognise is that patient safety is it's as risky and as unsafe to have incomplete or kind of non-objective versions of the truth as it is to have any other kind of risk. And so I think what solutions like the Aaron's team and Isla bring is the ability for a very objective truth to be created about the state of a patient's health. And to take a recent example from an implementation that we've been doing with Nottinghamshire Healthcare in the Midlands, they've done a great job of starting to kind of weave in care homes and other stakeholders into that kind of data generation group, if you like, so that when it comes to doing a handover, some of the problems around, you know, the problems that we're all familiar with, agency staffing being perhaps being used to kind of fill in, and lots of changes in the people who are going to be doing visits and delivering home care, it becomes really important that we have an objective view of what has happened with this wound, how has it developed and changed over the last 7, 14, 21 days. And so I think these sorts of technologies allow a whole group of stakeholders to very quickly build up that objective view. And I've sat in many handovers where, you know, the handover is a verbal description of a wound and how it's changed or how it's looking. And that's really quite risky, I think, and kind of creates a safety concern, because you're essentially going in to review that wound almost blind. Whereas with the right technology, you can go in and in the palm of your hand, you have the entire history, both visual and in structured data of the wound and the way that's developing, which gives you a much better starting point to then make your assessment and decide on the right intervention. So I think that's one of the real patient safety benefits of developing and introducing the sorts of technology that we're talking about.
I'm just looking while
Actually,
sorry, Bruce, go ahead.
Could I just add something to that got another thought in my mind, and this is kind of a little bit off topic, but it does relate to safety, and that is the engagement of the patient in the process. So by capturing this information and making it available to the patient, they get much more involved in the process and are able to understand what's happening and take really, in some cases, control of their care. There was one example I'm quite familiar of where a patient was being treated in the home. They had some quite severe pressure ulcers, and they claim that Silhouette, the product that we use, that Silhouette saved their life because it gave them hope and it gave them information. And when the nursing staff came, they had the whole background. And if it was a different nurse, they could ensure that that nurse was familiar with what their history was. And the information that the system had provided, it gave them that knowledge and that ability to really take control of their care. And so I think it's maybe not often talked about, but that patient level of patient engagement that these systems can provide is quite significant. So you're probably seeing that as well, Pete. So.
Yeah, absolutely. I couldn't agree more. There's you know, we're probably still at the starting point for this. Really, there's such an opportunity to begin to engage patients and to your earlier point, you know, family members and anyone else who can kind of support patients, and start to provide much richer context, much richer information about wound care. You know, some of the preventative measures, pressure ulceration is obviously a huge factor. There are really impactful kind of interventions which we can make around the entire sort of stakeholder group around a patient. So can we move to a model where it's routine for someone who lives with a patient who's at risk of pressure ulceration to just be doing simple checks, and starting to feed some of that data into the health system in a structured way. I think we're not quite there yet, but it's really exciting where we could go with these sorts of technologies.
I'm just looking while you guys are talking at some of the comments that are coming in. I can't catch them all, folks. Scrolling up and down, but I thought an interesting point that Natasha raised was, and thank you, Mike, for answering some of these, because it helps while we're talking as well. Natasha was talking about digital technology sounds great, but I worry that it is taking over from face-to-face contact with healthcare professional professionals to patient. I mean, I kind of don't see it like that. So there's that comment, but that's my view. But also, she's flipped that over by saying, I also see a place for it definitely in light of staff shortages. And Mike's replied on that saying, yes, he couldn't agree more. I think what we'd like to see is there is as little burden of collecting the information as possible. Hence make it clinically relevant first. With that data in place, we can shine a light on how busy services are. So there's that issue of, I suppose, is there a possibility? I mean, we lightheartedly talked about my parents having to send a picture in rather than seeing somebody. There's that side of it, but there's also a side where it could allow more people to see more people because the technology speeds things up. So I could there's two sides to it, really, isn't there?
Yeah, no, there definitely is. On that last point, we had a nurse who was overseeing a few long-term acute care hospitals in the United States, so kind of post-acute care, and she would say that our product gave her 100 sets of eyes, because she was in one location and she had nurses working in different locations, and all of that information was coming back for her to review. So she was able to sit in her office and basically see the information from patients across all of those different facilities. So certainly there's that aspect of it.
Yeah, I mean, I'm probably a bit old school, but I kind of worked in an environment where you dealt with something and it was dealt with, and then you moved on to the next thing. With this one, you've got to, I presume it isn't finished because you've then got to go back to the office and start looking at the data, etc. So I don't know whether that flips it over again. But it allows you to have an overview. In her case, it allowed you to have an overview of all of the patients that were under her wider care. So she wasn't seeing those patients day to day. She had nursing staff who were seeing them. So it just provided her a way to do this. Also, we do a lot of work with the Department of Veterans Affairs in the United States. So they're the world leader in telehealth, I'd suggest. They're really advanced in their adoption of telehealth, and they use our product quite extensively throughout their network to gather information. So their veterans will go to a community clinic where they're imaged and assessed, and that information is then sent off to the main hospital. And the main hospital, the wound care staff in the main hospital can make decisions about, yes, they need to actually be transported into the hospital, or no, you just apply this dressing. So they're not wound specialist people at the community clinics, but they're getting instruction from the wound specialists. And so it does lead to huge advantages in terms of transportation costs and reduction of costs. So the whole telehealth model, I think, has a lot of promise for developing quite significant improvements in care, especially as what we've been talking about here, when people start capturing the data in their homes and making that available. It makes things much more convenient for the patients and much more cost effective. So. I want to pick up on a question Pete's just raised from Victoria over in Nigeria. Hi, Victoria. How can developing countries like mine benefit from this and implement for effective wound care? We are talking, of course, at the moment in countries where there's a bit of money. That's debatable, but there's a bit of money. It's developed countries. Opinion on that, Pete? Developing countries?
Yeah, I think it's such a huge challenge to sort of, as rapidly as possible, take examples of good practice or technology which is working and then make that available as widely as possible. I wanted to pick up on it just because, and actually, Bruce, it'd be interesting to hear from your experience as well, but we're just kicking off a really interesting project with the ERHA, which is one of the regional authorities in Trinidad and Tobago. And really their setup is very, very different to what we're familiar with working with the NHS. But it's been a fascinating kind of, we're right at the early stages, but it's fascinating so far the way the discussion is going, and some of the changes that we're learning a lot, I think, about the way that our technology can be easily implemented. So to give you a tangible example, at the moment, most of our patient submissions are made through a link which is sent via SMS or email, and the NHS has reasonably good coverage of patient demographic, or those patient demographic details, through things like the NHS Spine and other data repositories. That sort of doesn't help in the use case of Trinidad and Tobago because text messages are very, very expensive, and so a lot of patients aren't able to receive links in that way. So what the process they're going through is actually taking the secure link and then sending that through WhatsApp, which is something that it's kind of on the cards for the NHS, but definitely isn't being driven. I wouldn't say as quickly as it is perhaps in some of the other health settings. So that's a change that we'll make to our product, particularly to support the Trinidad and Tobago use case. But I think as we go through it, there'll be all sorts of tweaks and changes to the technology which can be made to make it very effective in different health settings. So yeah, I just think it's a very exciting time because we can fast track, I think, for other countries many of the learnings that are developed in, you know, perhaps in the US or in the NHS or wherever.
If I could just comment briefly on that, we've done some work in West Africa. We had we're working with the World Health Organization to do a study on a Buruli ulcer and therapies for Buruli ulcer in Benin and Ghana, and they were using our technology, gathering information there. And I can say that we are in discussions at the moment with another country in West Africa about how our technology could be applied in more rural settings in that country to improve the wound care that would be provided. And as Pete said, I think the technology is evolving quite significantly, and so we're now seeing standard consumer products having the ability to gather the information and make improvements. And so we're seeing a kind of the becoming more accessible, more affordable for implementation in many parts of the world. So
some of the comments coming in are about self-imaging, kind of just flicking through these, and I know Mike's picking up on some of those. You know, somebody was saying there that they had to take an image of their own leg, and it would have been easier to take their leg off and photograph it, which I kind of get where they're coming from. All very good, but how do I take my leg off? I'll take that tongue in cheek, but it's a fair point. And Mike was just saying there, we're tying this into part of NWCSP assessment. One of the recommendations is to assess whether a person is eligible for supported self-management. So again, it goes back to that patient issue, isn't it, of trying for it to be inclusive for everybody. And some people won't be able to engage with that. Any more comments on that one, on how much the patient has to be involved in self-management? I think we've touched a little bit on that one, but we kind of touched on another person doing that. But easier technology, advice on how people can use technology, leaflets. I don't know how much more we can say about that.
I guess to come back to Bruce's point, I think we should all accept that there are going to be, you know, large numbers of patients for whom self-management isn't going to be the right route, isn't appropriate. The example in the chat, you know, is a perfectly good one. Of course, this isn't going to work for everybody. I think the real benefit though is that if for the cohort of patients where this is appropriate, we can be driving really significant patient benefits and financial benefits through the health system, then all that does is frees up funding to, you know, to begin to offer more personalized, more tailored services for patients who do need that physical intervention. And so I don't think there's a provider in, you know, anywhere in the UK that is able to kind of meet the demand for visits and see all the patients that they would wish to see as regularly as they can with one-to-one, you know, patient or nurse visits to the home. And so the more we can do with technology, the more we can free up that capacity to give people where the only option is a face-to-face visit, you know, free up providers to be able to provide that service. And so I think it is a question of moving forward as quickly as we can with technology, whilst being very respectful of the challenges that some people are going to have.
Yeah, I'm wondering whether, so I was going to say, Bruce, whether as the generations move on, are we being ageist here? I'm sure there are young people who don't engage with technology, but one presumes, as Pete's implying there, ultimately, we all use the internet now vastly, you know, and we all use, you know, that this problem will ultimately fade out as it becomes part of everyday life, like televisions and dishwashers and everything else, that people just, it becomes part of an evolving healthcare system.
Yes. Yes, no, I agree that my kids are much more fluent with technology than I am, and I think that'll just flow through the system. If I could just go back for a minute, one of the areas that we've noticed also is accessibility. So we all were familiar with the pandemic over the last 2.5 years, and one of our customers in the UK, Derbyshire, the diabetic foot service there has been using Silhouette, and they've reported that having a way to gather information in the home was actually quite critical during the whole pandemic. What they've been doing is trying to move the care from the clinic, so avoiding people having to come into the clinic and having those people being seen in the home, and and having that ability to gather information during the pandemic remotely, and when their clinics were not accessible, they found absolutely critical for the safety of their patients during that time. So I don't know if we want to talk about the pandemic or how technology could or how that's shaped technology, but certainly that was a big driver for us to get more into patient imaging in the home.
Yeah, I mean, absolutely. I mean, just some things that are coming up, because I want to talk to you a little bit about digital wound documentation solutions, because I know that's something we've been talking about, Bruce, etc. But a theme that's coming up a lot in these sort of notes that people are putting in there, Helen's raised it from Little Over Nursing Home, I'll give you a plug, Helen, is how can nurses working in nursing homes benefit from this technology? Any experience in that area, guys? Because someone else was talking about being able to take a picture and get that referred over to a tissue viability nurse and all this sort of connection. I wondered if you'd any comments on the nursing home, because as someone else was saying, chronic wounds community, you know, and that's where it seems to be happening.
Yeah, absolutely. So we're working in nursing homes in various places in the world. There's a whole bunch of advantages. You've got frail patients in nursing homes. Having them getting on transportation to go to a clinic is dangerous. They could get infections in those. They could fall. They could get infections. And so being able to gather the information in the nursing home and send it digitally to a consultant in a timely manner so you can get an instant review, I think that's something that can work very, very well and is working very, very well. So, I mean,
Pete, picking up on that one, all your remote working, etc.
I mean, yeah, I agree. It's care homes. There's often a very large percentage of the caseload for community trusts that are resident in a care home. And so it's a really crucial overlap. And so yeah, very similar experience to Bruce. We see most of the community trusts we work with engage with their care homes and enable care staff or care home staff to be collecting that information and pushing that back into the community trust. And I think one of the benefits of that is that we can, back to that point of kind of objectivity of the way a wound is developing and changing, you can shorten the duration between somebody seeing something that's a bit alarming in a care home and having like TVN input or specialist input. You can reduce that down to, you know, to moments rather than many hours where you're waiting for somebody to capture data on their phone, come back to base, email that to themselves, upload it to their EPR. You know, all of these incremental delays can often mean hours or days before someone is able to make an objective review based on the data. So I think it's hugely valuable for care home teams to be involved in this and to be pushing in that information into the system and receiving support from the health system as quickly as possible.
Okay, I'm just going to ask Mike in a second to chip in. Just some points. Anne was raising an important point about national standards, which we touched on earlier. You know, mobile people who are on holiday and trying to keep, you know, the same standard up. There are too many programs that don't talk to each other, and patient care can be accessed easily if you know, we're talking about technology here and national standards. And also technology enables staff to have a record of what was to compare with what is. unless you can compare, you have no way of knowing if things have improved or deteriorated. Mike, did you want to chip in on any of those issues at all?
Yeah, thank you. I was just following on from Bruce and Pete's thought processes or their explanations there. I think quite often, the use cases we're describing here is patients or people taking images of their wounds and how valuable that is, and the comment about that being an accurate record of what the wound was, so that you can compare how healing was. I think some of the power of the technology here as well is if we can start to collect the right data, as is always the case, what we can then start to do is think about, well, how do you manage cohorts of patients? So rather than just individual patients, can you see which patients are going off, in terms of, they're deteriorating, they're not healing as you thought they would. So it's when you start to look at, patients in the aggregate that you start to get some of that real power and potential. So, once you can do that, you can start to think, well, how do I organise my workforce to try and, best meet those needs? So I think it's sometimes it's about not necessarily losing sight of the value of looking at a patient group and seeing what's happening to them, and and some of that will be at a distance, and some of that will be people turning up into a clinic, but you might be better able to stratify your patients and the wounds that you're seeing by having that data available to the person at the point they're seeing them. And there was one, I think there was something just around interoperability, and Anne and I were only talking about this yesterday. I mean, I think there is something we have to do, I think, in this space, which is, recognizing that there are challenges with integrating across systems is sometimes almost be quite brutal in thinking about what information we absolutely need to pass across systems. I think some information can stay in some systems because it's absolutely right that it sits there, but we have to really think about what is the absolute, what are those absolute bits of information we would want to pass into another system. I think quite often we can come up with quite large requirements, which we obviously want to get to, but integration might need to start somewhere. That interoperability needs to start somewhere. So we might need to lower our sights a bit to make the process work.
Yeah, that sort of lends itself to, I'm aware both Pete and Bruce have a lot of experience of implementing these things, but we haven't really sort of said what is being implemented, really. And I know, Bruce, you wanted to talk about digital wound documentation solutions, which may link into what Mike was talking about, because we're kind of skirting around the issue as to what actually is this technology that actually people are using. Did you want to comment, Bruce, on digital wound documentation solutions? You're on mute, Bruce. Sorry, it's early in the morning for you.
I was being a good person and muting myself per instructions. So we've covered quite a lot of it already, what a wound documentation system is, but you need to be able to gather the images, gather the measurements, and we've spoken about the real importance of consistency and confidence in those measurements. So you need to then look at how you're going to implement that system, and what has to be done, what change management needs to be done, what workflows need to be in place. You need to get the buy-in from various people in your organization to make that happen. But what you're really implementing is an electronic system where you've got a storage of information where that information can be gathered and analyzed, and as Mike was saying, decisions can be made about across the population of patients. But you're gathering that information in a consistent way, and with some way of ideally easily gathering that information with a mobile phone. So in our case, we use mobile phones, and we also have a camera that's specifically made for wound care. So we have a whole range of different solutions that can be used in different care environments. So you need a way to gather that information, and it's ultimately a digital software system that you're working with. Yeah, so I'm not sure what else I can say about that. Pete, you might have some thoughts.
Yeah, as Pete, and also Pete, the things that you've been working on that people are interested in, and things that maybe people don't go with, just what the technology is.
Yeah, for sure. I mean, I think Bruce summed up a lot of it well. One of the things that we've implemented recently is the ability to kind of start to automate some of the flow of information from patients or from care homes or from family members or whoever. And so we built in functionality like scheduling so that we can schedule a series of requests to a stakeholder over time, and that might be, can you send us a, can you update the digital wound information every 2 days, and can you we might want to run that for a period of a month, let's say. So it's those sorts of, I mean, probably don't want to go into just like a long list of features, but I think it's those sorts of features that make it really scalable to begin to implement these sorts of solutions. On the more experimental end for us at the moment, and this is actually more relating to surgical site wounds, we're doing a really interesting piece of work with one of the clinical teams at Guy's and St Thomas and a few others, University of Edinburgh and others, which is to start to use the data set that is being collected to begin to understand the potential for computer vision to pick out some of the more concerning features from an image set. And so that's really interesting. And we're looking within surgical site settings, we're looking at 12 different risk indicators. So things like diathermy injury or gaping of the wound around closure materials, that sort of thing. And it's a long process to build that technology, but it's the sort of potential that is opened up by having a digital wound management system in place, because you can begin to build a really structured data set. And I think that's exciting for today, but also for the future of kind of wound care and other healthcare specialties.
I mean, just sort of saying to everybody who's listening in, I did say, if you want to pop in the chat box what your next steps might be from what you're hearing, what are some of the things you're viewing would be things you would do over the next month or two? Is it to look for more technology? Is it to look at where technology could help in your particular area? Do put that in the chat box. I mean, picking up on this measurement thing, Judith was saying, I like the idea of using the technology. I think you'll get a far more accurate picture, especially with pressure sores, which I believe are open to individual interpretation with current grading levels. So that comparison coming in there. Mike, I'm not sure if you're still there. Is there anything else you wanted? You've been answering a lot of the questions that are coming into the box. Is there anything else or anything you've seen there to pick up on as we sort of head towards the end?
I've been trying to do as much as I can in the chat, in the Q&A. I think I suppose there's one final reflection maybe, and I think it's prompted by Anne as well, is that with a lot of focus here is on the digital and the technology, but we do need to view it as of all of the changes. So a lot of the questions are around capability of people to actually take self-imaging, and I think we do need to view this through the lens of the people, like the capability change, the educational change we need to see in both the people delivering care and those receiving it. And there's also the pathway, the process change as well. And we need to view all the great exciting things we're talking about here, through the lens of that broader change that we'd like to see in wound care services. They're each independent on each other, right? But I think we need to look at it as a whole. And often we can look at, as we tend to do anywhere, I think in life, is we tend to look at technology being the absolute solution to the thing we're trying to resolve. We do need to bring, we need to have people change, we need to have process change in order to make that happen as well.
Yeah, absolutely. There was a question there, Mike, about are there any effective nursing healthcare worker tools in place specifically for wound care that are in a structured format for data collection? That probably makes more sense to you than me. I think you've touched on some of that.
Yeah, I mean, if we can put the link in the chat, but we've got a link on our website to systems that we're aware of that support wound management, so we can put that link in there. So there is a register out there of things that we're aware of nationally. That there may be new entrants, but that might be a place to start. But again, I sort of advise that person to make sure that we're thinking about this in the round rather than plug in a tool and think that everything will get better. Yeah,
absolutely. I mean, Pete and Bruce, is there anything as we wind down and finish off that you wanted to put forward that I haven't captured in the comments and in the questions?
From my perspective, technology, we've been talking a lot about technology, but I completely agree with Mike and Anne that a lot of it comes down to the people. and getting the people on board, getting the people engaged, and the changes to the process. The whole change management in our experience is so important to manage that well. And we've had quite a lot of experience now with implementations that have gone well, implementations that haven't gone so well. And a lot of it does come down to the people and the change management processes. So when we do implementations now, we really do focus on that whole point. A part of it is the technology, does the solution work? But that's not the only thing you've got to concern yourself with in terms of having a successful implementation. So that would just be my final thought.
Yeah, and Pete, adding to that, just your final thoughts.
Yeah, I was going to make the same point. I think Bruce has very succinctly summed that up. Of course, technology is not a silver bullet, and technology that sits on shelf and no one uses is of no use or value to anybody. So it is absolutely about kind of the hearts and minds, the training, the implementation of the new process, and making sure that's done sensitively, but as progressively as possible. So yeah, I really agree on that point. As equally as important as kind of thinking about the technology that might support you is think about how the organization is actually going to implement this, and over what timescales, and what are the resources that you're going to need internally, who are the champions for this. All of those questions are really, really crucial.
Yeah, I think also we could talk about organizational culture as well, can't we? And the things that encourage change. We've all worked in areas where they change and it's encouraged, and it's a learning environment, and others where it's very, very closed down. I'm just looking at some final points there. I think it might be worth noting that the implementation of remote technology is based on the assumption that wound assessment is predominantly a visual process. It's not. We have sort of veered over to that visual thing, haven't we? How do we enable a full wound assessment with new technology? So there's all that as well. That it's more than just visual as well. I work in a private hospital. How about funding for this technology? Does the technology take cognizance of, I'm impressed that somebody can spell cognizance, I can't, cognizance of comorbidities in wound care, for example, diabetes, looking forward to how diabetics, people with diabetes can affect how diabetics can affect the prognosis of a wound. I'm sorry, I'm reading this. Nutritional advice incorporated into wound care and technology. Yes, I think I've caught everyone. I'm just aware, everybody, of making sure all your comments. Technology helping in, we are discussing use of technology helping in my vaccination centre. It's obvious that many people do not have a standard mobile phone to book their vaccinations, so smartphones are not in common use for many people. We've kind of touched on that a little bit with personal experience. Helpful innovation, but some people only have a landline. Will GPs be involved in this process of technology initiative to help reduce the long wait in ED? Yes, mental health and so forth. Okay, I think I've probably caught everything. Do you want to touch on that, Bruce?
Oh, there was just one question there I saw floating past about data security. So we spend a lot of time on data security, and customers are very interested in that, and the informatics people. And on one hand, putting in a system like this actually improves your data security, because it's discouraging people from taking photos on their mobile phone, and which are completely unsecure. So having a system that manages this in a secure way is actually significantly improving data security. So generally, when we find that the IT people, the informatics people are actually very pleased about a system like this going in, because it's going through the proper processes. So.
Yeah, I mean, that issue I've scribbled down ethics as well, all of that side as well. Okay, I'm going to wind things down now, folks. I've just made sure I've tried to capture as many questions as I can. I think we've covered most of those. Can I just thank sincerely for helping me through Pete and Bruce and Mike and Rebecca, who I know has slipped off. I'm sorry we didn't get Luxme, but we'll try and do some magic and get that presentation to you. But I hope you found it useful. If you want to just put some final comments, folks, in the box, that would be very welcome as well. But I'll let you all go now because we've just done it under 2 minutes. 2 minutes to go, so that's fine. But thank you, everybody, for being part of today. Thank you very much.
Yes. Thank you.
Thanks very much, everyone.